Welcome to Essentials of Clinical Supervision. My name is Dr. Tara Jungerson, and I'm an assistant professor here in the Mental Health Counseling Program at Nova Southeastern University. Today, in this 2-hour webinar, we are going to be talking about some of the following objectives. Today, it is my intention that attendees will leave the session with a clear understanding of clinical supervision, that hopefully you will be able to identify key characteristics of the roles and responsibilities of both supervisees and supervisors. And also we're going to review Bernard's discrimination model as one of the main theories of clinical supervision. And along those lines, we are going to discuss the protocols and practical strategies in supervision across these roles and foci in Bernard's model. Finally, we're going to talk about the process of credentialing of supervisors both in the state of Florida and nationally. So these are the order in which we're going to be covering, starting off first with definitions of clinical supervision. Before we get to that, I want to talk a little bit about my background and interest in clinical supervision. I became interested in the research more fully once I got into my doctoral program. After having worked in the field for about 10 years and between my master's and my PhD, I found that there was a very wide variety of supervision models and techniques being used, and definitely a wide variety of supervisors and types of supervisors. I remember the support I received from my first individual supervisor in my first practicum, along with facing my initial fears of being in front of a client for the first time, or the invaluable learning experiences I had in group supervision with multidisciplinary team members. I also remember being challenged as I developed my own identity and style. So looking at my dissertation research about clinical supervision, I noticed that it was different based on the location of where it was being conducted, the context of the supervision, the types of clients served in the different sites and agencies, but also varied due to the clinical orientation of the supervisor. So I wanted to further explore how to translate the supervision research into more practical strategies for this important training component. So each of you that are watching this webinar have either experienced clinical supervision in the past, perhaps you're currently providing clinical supervision, whether it could be in the schools, it could be community mental health, it could be college campuses, inpatient settings, residential settings, and others. I want to ask you to kind of think back to what your own supervision experience was like. What were the best and worst parts of it? What was something that you would have liked more of in supervision, or maybe less of in supervision? Also think back to what were the relationship dynamics like between you and your supervisor or multiple supervisors. So hopefully your answers to these questions and your thoughts about these questions will help ground us somewhat in the content in which we are about to explore. So to start off and talk about some of the definitions of supervision, I'm going to move past the Webster's Dictionary definition of supervision, which is to oversee, and talk about the definitions of clinical supervision. It is an ongoing educational process, and the key word there being educational, where the supervisor aids the supervisee in acquiring appropriate professional behavior through an examination of the supervisee's professional activities. Another definition that we could consider with clinical supervision is that it is an intervention provided by a more senior member of the profession to a more junior member of the same profession. And I think this second definition especially talks about the relationship dynamics that are inherent in the supervisory relationship, which we'll talk a little bit more about today throughout the presentation. Supervision is a relationship that is evaluative. In other words, there is going to be an evaluation at the completion of the supervision term. It extends over time, and it has the simultaneous purposes of enhancing the professional functioning of the junior member, monitoring the quality of the professional services offered to the junior member's clients. And I think that's key because the purpose of supervision is ultimately for the protection and welfare of the clients served. But also supervision serves as a gatekeeping process for those who are about to enter the profession. And the gatekeeping process occurs in different parts of the clinician's development. I also want to compare supervision to some other processes that are similar in practice or sometimes in nature. First, I want to compare supervision versus education. There are some similarities in that both involve teaching and learning. The supervisee is learning some of the key points of the profession, maybe learning clinical techniques and intervention, and the supervisor has this professional knowledge to pass on through this didactic process. Also, both have evaluative aspects. Both the supervisee and, for example, a student at the end of an educational process are going to be evaluated at the end of the term. And both are time limited. There is a start date and a stop date for supervision and also the educational term. But there are differences. With education, there is a uniform curriculum. There's the similar goals and objectives. However, with supervision, that will change based on the context and the supervisee's needs and the site. I also want to talk about the difference between supervision and consultation. Consultation the supervision can evolve into more of a consultation for more senior level professionals. And so this is a way for these senior level professionals to get ideas on how to handle a particularly difficult client or to regain needed objectivity. Typically with consultation, that is sought out freely. And that is one of the differences between clinical supervision and consultation. Consultation is freely sought, it's non-evaluative. Also, when you think about the practice of supervision versus the practice of consultation, it's a lot easier to disagree with a consultant versus your own supervisor, at least in face-to-face. Parties are also not necessarily from the same discipline when a consultation is completed. In fact, that's many times when a consultation is sought out, is when there is expertise needed outside of the normal professional functioning. So I think that one of the examples of consultation that if anyone's ever watched the TV show The Sopranos, when Dr. Jennifer Melfi sought out supervision, which was more of a consultation role for her in how to deal with her mafia-connected patient, Tony Soprano. And one of the key points I want to focus on is the difference between supervision and counseling and therapy, because this is something that comes up very frequently in supervision trainings and also within the supervisory relationship itself as to the amount of personal development that the supervisee is going to go through within that supervisory relationship. The similarities between supervision and counseling and therapy are that both of them involve helping someone, whether that be the client or the supervisee, examine aspects of their behavior, their thoughts, and their feelings. The therapeutic intervention with the supervisee, however, should only be in the service of helping the trainee to become more effective with his or her clients. So any sort of focus on any sort of the personal behaviors, thoughts, or affect is going to be only as it relates to the clinical service and the clients. The differences between counseling and supervision would be that a supervisee is typically not given a choice over who their supervisor is, and they're not given a choice about whether or not to receive supervision. And typically with a client seeking services, they can have that choice and they can decide when to stop. Also, there's going to be a different initial contract. And we'll talk about contracting later. However, therapy involves helping the person deal with personal issues, whereas again, supervision focuses on professional issues. And we need to keep that in mind within that context. Other similarities and differences with counseling and therapy. Both involve a power differential within the dynamics. But the differences are that the evaluation piece. Because with evaluation of a supervisee, the results are very different and have a lot more significance and impact on the person than perhaps an evaluative or diagnostic workup of a client, unless we're talking about a court-mandated, court-adjudicated client. For example, if I have a poor evaluation of my supervisee, it may result in a delayed graduation, even prevent graduation if we're talking about interns. It may prevent licensure if this is postgraduate pre-licensure supervision. Whereas my negative appraisal of a client may not have any concrete life-changing consequences, again, unless we're talking about the court-mandated clients. Another thing to consider is that the time spent together between supervision and direct clinical work are going to be different. The supervisor typically has many more opportunities to observe the supervisee. There's different contexts for observations. They may be in staff meetings together. They may be having lunch together. There's a lot more opportunity to observe the supervisee, whereas a client, depending on the site or the context, a therapist may run into their client once a week. There is more self-disclosure, typically, by a supervisor in supervision than would occur in a counseling or therapy session. And we'll talk about the pros and cons of self-disclosure, but it's typically more of can adopt more of a mentoring process where sharing some personal examples of how a client situation might have been handled in the past would be an appropriate self-disclosure. And there are different boundaries between supervisor and supervisee than there are with client and therapist. And I put a question mark by this because this is one area that supervisors and some of the research differ, is are the boundaries exactly the same as it would be in a clinical relationship, or are they different? And I think you're going to hear different versions of this based on personal style, based on where the supervision is occurring, and sometimes based on both supervisee and supervisor characteristics. Now I'd like to move on to the roles and responsibilities of supervisees. I think when before we get into the actual responsibilities of the supervisees, we need to look at some of the common expectations with which a supervisee will enter supervision. Some may not know what supervision looks like. They may assume that it's a very passive process where the supervisor more or less is the expert that bestows knowledge kind of from the top down to the supervisee. Others may have had experience with supervision and realize that it is that exchange between the two. But either way, there is typically some anxiety that is occurring especially with a very new intern or practicum student. There is this need for impression management because the perception by others can be a contributor to the anxiety that the supervisee is experiencing. And a lot of times they're dealing with this imposter syndrome where they question their competence, they question their abilities, and sometimes that providing them that support to fake it till you make it in some ways, and supporting those supervisees with lower levels of autonomy. In fact, we'll talk a little bit about Stoltenberg's IDM model, which is the integrated development model, which acknowledges that supervisees and trainees start and develop throughout their training process with different levels of cognitive complexity and different levels of motivation, different levels of autonomy, and definitely different levels of awareness and self-awareness. So the newer supervisees tend to be very rigid, tend to think in very black-white terms, are extremely anxious. And then throughout the process, throughout their experience, they tend to move towards increased autonomy, increased reliance on themselves, and begin to integrate different pieces of the client, their curriculum they've learned, professional ethics, and also multicultural variables and multicultural competence. Sometimes the supervisee moves towards higher levels of autonomy and maybe even less willing to take feedback from supervisors. However, most come with a willingness to learn, and it's been my experience that those that do have a sort of overdeveloped sense of competence usually get tempered by the clients, depending on the therapeutic outcome. So again, just to talk a little bit about specific needs and roles and responsibilities of intern supervisees or practicum student. We'll talk, this will be the pre-graduation experience. The interns are focused on combining educational praxis with the application and integration of the knowledge and skills. Again, this is getting at Bloom's taxonomy where they're actually applying the knowledge that they've learned. They're responsible for accumulating direct clinical contact hours, and that's going to vary based on the curriculum, based on state licensure requirements in the respective states, and it may differ by profession. There are also many indirect services at the site that the new prac student or the new intern is having to synthesize and incorporate. And this can kind of lead to the anxiety of just performance of the clinical skills and appropriate interventions. A new intern is going to be learning the referral sources and the referral process, both of intakes and discharges at their particular site. They may be attending staff meetings and trying to navigate the dynamics of a group composition at the site. They may be attending treatment team, learning different models. For example, maybe shadowing a psychiatrist, learning about medications, possibly shadowing an addictions counselor, running A&D groups. There are also definitely learning documentation. And while there are many documentation pieces that are common across all sites, the differing paperwork, the different lengths of the intake assessments, the treatment plans, the treatment plan revisions. These are all going to differ by site, and there's a little bit of a learning curve with that process. Also, keeping in mind, interns have what's called concurrent supervision. In other words, they have their site supervisor, who is their typical one they are staffing their cases with, who is responsible for the intern's work there at the site. But there's also going to be a faculty supervisor or university supervisor who will also likely be conducting group supervision at the same time. And so I think it's really important as professionals that the site supervisor and the university supervisor are coordinating and monitoring, because we all see the interns in different contexts and can see different pieces of information to put together a more comprehensive picture of the trainee's strengths and areas for improvement. So some of the supervisee responsibilities, and these are going to depend again on the context of the supervision and on the contract that the two of you work out, but the supervisee's responsibilities are to know the general purpose of supervision, to recognize that different supervisors will attempt to achieve the purpose of supervision in a variety of different ways. And it's been my experience that this can be a source of frustration for some supervisees, but at the same time, it's also a gift that as they discuss in group supervision with their peers, the techniques that one supervisor uses or the focus that one supervisor has versus the other, and learning about all the different ways that supervision and training can be completed. And one's not better or worse than the other, they're just different. And this helps the interns with their tolerance for this ambiguity that doing therapy, doing supervision is not a cookbook approach where you do this and this and this and this. And I think that helps their cognitive complexity to consider all of these different aspects and different ways that the training can occur. Also, the supervisee has the responsibility to accept that there is going to be a certain level of anxiety associated with the supervision process. This is a parallel with counseling and therapy, that there does need to be a certain amount of challenge, amount of anxiety that goes with that challenge in order for the supervisee to grow. The supervisee also is responsible for asking how and when the evaluation will occur so that they know what to expect. They can clarify any questions about the supervision contract, and again, we'll talk about contracts a little later. And supervisees do have a responsibility to strive to be as honest as possible during supervision. Now, this doesn't mean that they have to completely self-disclose and be sharing all these intimate secrets or details of their life. However, they do need to strive to be as honest as possible about a self-evaluation and some of their buttons or their roadblocks, again, as it's impacting the client, as it's impacting their work. They also have the responsibility to ask for what they need. In fact, this is a great question for supervisees within the supervision process, especially whether it's the halfway point, the midterm eval, the final eval, is what do you need from me? Or what am I leaving out? What is working well? And making sure that that supervisee is taking ownership of the supervision process and of the time and how it's used. Also, the supervisee does need to spend time preparing before meeting with the supervisor. I like my supervisees to come in with specific questions, with specific cases, to show that they are using the time for their maximum benefit. Other responsibilities include obtaining and enhancing ethical clinical skills and knowledge. This is, I think, hopefully pretty obvious that we want our supervisees to be practicing ethically and also utilizing appropriate clinical skills. Practicing within the bounds of competence and knowing where those boundaries are. Demonstrating cultural sensitivity and competence across different cultures. And supervisees also have the responsibility to complete their work products, whether this is documentation, treatment plan reviews, assessments. That is their responsibility. And dealing with challenges or consequences of not having a work product as well. And the ability to accurately self-assess. And hopefully this self-assessment is a mutual process, but with many different data points for that assessment, but to know their strengths and what areas to focus on as they grow. Now let's talk a little bit about the roles and responsibilities of supervisors. Keeping in mind that clinical supervision has dynamics, we have clinical aspects, there are legal aspects, and there are ethical aspects, all of which have to be considered within the supervisory hour and a half. Realizing that clinical supervision is the primary means by which clinicians and their supervisees ensure that the legal and ethical responsibilities to the clients, to the profession, and to the public are fulfilled. Because that supervisor is monitoring and overseeing what is occurring. The supervisor is also responsible to facilitate the development of therapeutic competence in the supervisee. And this is a focus both in the university level but also in the field, is focusing on particular competencies. That it's not enough to know that, or that the supervisee knows what to do or knows what the interventions are or which interventions to use, but to demonstrate competency in providing these interventions. I want to talk about a few more of the responsibilities of clinical supervisors within this process. The supervisor responsibilities, and again, it's going to depend on the context and the site and the contract you design with your supervisee. But you have to recognize that you, as the supervisor, are ultimately responsible, both legally and ethically, for the actions of the supervisee. You have knowledge of every case and client with whom the supervisee is working. And there's different ways of tracking this. Typically, I try to put that responsibility onto the supervisee. However, some agencies or facilities have electronic documents that there's a way to electronically track who is on the supervisee's caseload. And you may be able to find a way to incorporate that into your practice. Also, you are responsible to provide feedback and evaluation to the supervisee regarding performance. And we'll talk a little bit about evaluation later on in the presentation, but I like to say that when the supervisee comes in for their formal evaluation, that it shouldn't be a surprise. There shouldn't be any curveballs coming out of nowhere, that this evaluation process is occurring over time. In fact, maybe in each of the supervisory sessions of checking in about performance, giving feedback, which again, giving feedback can always be a challenge sometimes, but it is our responsibility as supervisors. We monitor the actions and decisions of the supervisee, including decisions not to act. We document the supervisory sessions. And we also supervise only within the scope of practice and expertise and refer out for additional supervision or consultation as necessary. For example, recently I have two supervisees that at their site, they are doing supervision primarily to Spanish-speaking clients. I myself do not speak Spanish. Therefore, I am utilizing a consultation with some colleagues to assist in supporting their supervision or their clinical work, watching their tapes to help me support those supervisees as best as possible. Also, providing supervisees with due process information. Due process is outlining the procedure for handling adverse actions, and it's also outlining the disciplinary procedures and actions and the appeal rights that the person has. And again, this gets into when there is a negative or an adverse evaluation of a supervisee, but the supervisee has the right to know the process by which any disciplinary actions occur. Also, the supervisor is responsible to have this written contract regarding the scope and expectations in supervision and the responsibilities. When we talk about the dynamics between the supervisor and supervisee, I like to point out that supervision is an isomorph for therapy. In fact, there's studies about isomorphism within supervision that are being done. But isomorphism means that they are structurally identical, and the dynamics that occur are also very similar and almost identical. Just for example, just as in therapy, when sometimes what is not said can be more important than what is said. And so when I think about that isomorph and when I'm identifying themes in supervision, I'm looking at what is omitted in your supervisee's case conceptualizations. When the supervisee brings in a case or brings in questions, what are they asking about, but also what are they not asking about? Because we can't assume that if it's not brought to our attention that it's being done. Also looking at parallel process. For example, a parallel process between what is going on between you and your supervisee and what might be going on between that supervisee and their client. For example, I might say to my supervisee, I noticed that when I ask you about your client's alcohol use, that you changed the subject to how the client is coping with the death of her mother. I wonder if this is occurring in the session as well, and realizing that can occur. And really the only way you're going to be able to track these is by watching tapes or sitting in the session as well to kind of confirm and check this out. Also realizing that supervision can include intensive interpersonal interactions as the supervisee is exploring some of his or her buttons or issues as they affect clinical work. There can be some sharing, and that needs to be treated with respect and sensitivity. The supervisor can function in several different roles. The supervisor may be a teacher, engaging in the didactic process, teaching how to implement the WDEP of the reality therapy theory. The supervisor may operate as a counselor, facilitating self-awareness and personal exploration, again, as it pertains to the clients and the clinical work. Supervisor is sometimes a consultant that the supervisor seeks out for that expertise. May serve as a mentor to the person. Maybe and also functions in the role of an evaluator or gatekeeper. Again, this is the ultimate purpose and function of, or excuse me, one of the purposes and functions, not the ultimate, but is a gatekeeper to the profession. Also, the supervisor may function in an administrator role, whether that may be granting or approving vacation time off or things like that. And we'll talk a little bit about those differences and some of the differences in the roles. But when it comes down to it, a supervisor is a professional role model. And the supervisee is going to look up to you as the supervisor to be modeling the ethical, the legal, and professional practice standards. And that is something that I have to keep in mind sometimes. Also, we look at ethical supervision and what that is, because some of these roles and responsibilities and functions do overlap. So, for example, I have here one of our components of the ACA, the American Counseling Association Code of Ethics, because it discusses the multiple professional roles with supervisees. So, for example, supervisors must clearly define and maintain ethical, professional, personal, and social relationships with supervisees. They have to work to minimize potential conflict, and also have to explain the expectations and responsibilities of each role. In other words, there needs to be clear boundaries and clear understanding of when I am your professor and teaching your class, I have these responsibilities and roles. When I'm your clinical supervisor, I have these roles. When I'm co-facilitating a group with you, I have these roles and responsibilities, and vice versa, what the supervisee or trainee's roles are. Another aspect of it, when we talk about dual relationships or these multiple relationships that can occur between supervisor and supervisee, I also added another piece of the ACA Code of Ethics, which talks about potentially beneficial relationships with supervisees. Because we're not saying just avoid all multiple relationships. I think that's impractical and impossible in most situations. However, supervisors must be aware of the power differential in the supervisory relationship and take precautions that there's not going to be any sort of exploitation or abuse of that power that is inherent. For example, you would take precautions similar to those you would take with clients with regards to non-professional relationships that could be potentially beneficial. So, for example, attending a formal ceremony, mutual membership in a professional organization, going to conferences together, maybe co-presenting at conferences, and sometimes even providing support during a stressful event. Again, those interpersonal dynamics within that relationship is typically there is trust developed, and you have to be mindful of that trust in these interactions. You also can engage in open discussions before entering into these relationships. And it's important to document that you discuss the boundaries, but also outline the potential benefits, any drawbacks, and anticipate any unintended consequences for the supervisee. So, something to keep in mind with the dual relationships. So again, when you're managing these, remember that some are unavoidable. You have to communicate about them. You may have pre-existing professional relationships, and then all of a sudden one person is put in the role of supervisor within your work site. You may operate social roles together. Professional conferences, agency events like going to a wedding or a baby shower. Multiple roles within the site or the agency. So you're both co-facilitating a group and you're the clinical supervisor. Hopefully it doesn't need to be said, but to avoid sexual relationships within the supervisory dyad, there again with the trust that's developed, there is the power differential, and that is an abuse of the power to enter into that sexual relationship. Always consult when necessary, because the reason dual relationships can be harmful is that they can cloud your judgment, and they can risk exploitation of the supervisee. So if you ever have the opportunity, and some may call it the luxury, to get what's called soup of soup or supervision of supervision, you can consider having a supervisor or doing a consult where someone watches you supervise your supervisee and gives you feedback about how you're doing, whether you're implementing a particular theory or model, and looking at your strengths and areas for improvement in the provision of clinical supervision. In fact, most counselor education doctoral programs require an internship in clinical supervision where this soup of soup occurs weekly. So getting back to the supervisor's functions and roles and responsibilities, sometimes we have to clarify the purpose of supervision, because organizational compliance and those administrative supervision of these organizational issues is separate from clinical supervision. For example, administrative supervision may attend to organizational matters, such as granting vacation approval, may deal with personnel issues, or the person's parking in the wrong parking lot, or they use the wrong form on some internal function. Our administrative supervisor has responsibilities to the employer, responsibilities for their own employment in this role, and usually also has requirements related to record keeping. So I'm sure you can see where it gets into a problem where the person that's administratively responsible for compliance about granting vacation approval being the same person that's trying to ensure that the supervisee is competent at implementing motivational techniques or exploring some of their personal issues that's related to their clinical work. I'm sure you can see where those boundaries get blurred. For example, a clinical supervisor is going to be more responsible for the professional development of the supervisee. It's led by a senior member of the profession, whereas sometimes an administrative supervisor may not be part of the clinical staff, may be a program director with different training and different responsibilities. And clinical supervision, there is a unique body of knowledge and skills, hopefully that we're covering a lot of today. But it does get fuzzy, and these roles between administrative and clinical supervisors do get blurred when there are issues like returning charts at the end of the day before HIM or medical records closes. Okay, yes, that's an organizational issue that as an administrative supervisor, you need to ensure that all charts are locked up before close of business. But it also becomes a clinical supervision issue in that how is this supervisee functioning as far as his or her documentation? Is he getting his notes done on time? Is there a block there that would be appropriate to talk about in clinical supervision? Also some other fuzzier issues that can come up that kind of blur the lines between administrative issues and clinical issues. Professional attire and how the person is dressing, whether high heels or open-toed shoes are not appropriate for an inpatient unit, or making sure there's a breakaway lanyard in these inpatient units. So some of these bleed across the clinical realm and the organizational realm, and so that's where it can get kind of fuzzy. But I think as long as you are clear about this, both in your own head and clear with your supervisee on which role you're occupying when you're addressing some of these issues, I think it helps clarify your purpose, and it clarifies the expectations for the supervisee. Now we're going to move on to theories of clinical supervision. Because just as you wouldn't want any of your clinicians working without being grounded in theory, the same goes for supervision. And while some supervisors utilize theory-specific models of supervision, such as psychodynamic or Gestalt or solution-focused, I want to focus on a major theory of supervision that was created just for this purpose, which is called the discrimination model. Jan Bernard created the discrimination model, and it involves what's called a roles and foci matrix, where the supervisor occupies the role of either teacher, counselor, or consultant, and then the supervision focus is either on intervention, personalization, and conceptualization. And it is not a lockstep process with this model. The roles and the foci, they interact and blend both within sessions and, of course, across supervision sessions. And a supervisor acting in the role of teacher is focusing on some of the more didactic issues, instructing supervisees, this is used with supervisees maybe with less experience, and may even take on more traditional teacher roles in assigning homework assignments for the supervisee, perhaps to assign a particular book to read or a video to watch about either the clinical topic at the site or agency or about a particular clinical intervention, such as child-centered play therapy. A supervisor acting in the role of counselor will focus on, again, not doing therapy with our supervisees, but temporarily facilitating personal reflection on what may be enhancing or detracting from their clinical work with clients. A supervisor acting in this role may also examine the supervisee's emotional reactions to clients, in other words, when their buttons get pushed. For example, some supervisees, especially young trainees, may not want to confront their clients for fear of not being liked. And this would need to be explored in supervision as it pertains to their work with clients. Also, some supervisors operate in the role of consultant. This is more of a collegial relationship, and in this role, the supervisor would focus on mutual problem solving. And when we look at the focus of what happens in the supervision session, intervention focus would include focusing on skills. In other words, what skills or competencies is the supervisee using, or what are they performing? And looking at the impact of the interventions on the client. A focus on personalization would look at the supervisee's personal style. How does the supervisee separate personal boundaries in their clinical work and separate boundaries from the clinical treatment and keeping, again, those emotional reactions out of the conceptualization? And finally, the conceptualization focus. This is how does the supervisee think about clients, and how does he or she decide to apply theory, and how do they apply it? How do they think about clients? How do they work to understand them? And that becomes sort of a metacognitive process of thinking about thinking. With that. So I want to put up this slide, which is more of the matrix form of Bernard's discrimination model. And if you look along the left-hand column, the focus of supervision, again, would be intervention, conceptualization, or personalization, whereas the supervisor role across the top may be teacher, counselor, or consultant. A supervisor operating in the role of teacher focusing on intervention would perhaps teach a new technique, such as systematic desensitization, to the supervisee. A teacher role focusing on conceptualization might use the session transcripts, have the supervisee transcribe a session, and teach the supervisee to identify themes across client statements within the session. A teacher role focusing on personalization might assign an article regarding proxemics or proximity to address the supervisee's cultural preference for a close seating arrangement that you notice might be impacting the client as they pull back from the supervisee in the session. A supervisor operating in counselor role, focusing on interventions, would help the supervisee determine the effect of a particular client on him or her. For example, let's say this supervisee uses excessive questioning with a particular client and not with others, and so the supervisor would explore that. A counselor role focusing on conceptualization would help the supervisee see her cognitive blocks in goal setting for an unassertive client, and as it relates to the supervisee's own lack of assertiveness. And a counselor role focusing on personalization would help, a supervisor would help the supervisee confront his own resistance to recognizing sexual cues from women when a client is obviously sexually attracted to him. And finally, the role of consultant. Consultant focusing on interventions would, at the supervisee's request, use a metaphor technique, help the supervisee expand the metaphor technique and apply it across different modalities of treatment. Or working in the conceptualization intervention or focus, a supervisor would discuss several case conceptualization models with the supervisee at her request and consider cases from a Gestalt point of view, from an Adlerian point of view, from a narrative point of view. Finally, the consultant acting in a personalization focus might focus on developmental concerns of older adults as the supervisee requests assistance in feeling more comfortable with this topic and working with that particular population. So again, looking at this matrix, you kind of have to, even while you're in the supervisory session, picture this matrix and picture which role you're occupying and where your focus is. And also documenting, when we talk about documenting supervision session, documenting to these different roles and making sure that you're covering each of the foci, but also being aware of which role you operate within. And some roles are, we're more comfortable in some roles, might be more comfortable as teacher, counselor, consultant, but also making sure that we're not omitting anything when we do our supervision sessions. So at this point, we're going to watch a video clip, and in this example, Lori Russell Chapin is going to be demonstrating the discrimination model with her supervisee, Brian. And Brian has been working with a client named Sydney, and Sydney is coping with the death of her mother after a long illness. And after several sessions, she is discussing her mother, and while her counselor, Brian, attempts to focus the session back onto the client. So we're going to pause here and watch a few minutes of Brian's session with Sydney.
He was always very muscular. So all the boys they were afraid of it because he was really broad-shouldered and not a bit heavy. There weren't an ounce of fat on him during that time. And he did have a very, very bad temper, which I'm sure he got from his family. And my mom did too. But he was also a loving person in his own way. And after he had a stroke, then it came time for Bob to get out of school, and he was getting this offer to come up here. And I didn't know if it was right until he came home, and my mother, the best thing she ever did for me. And I won't cry again. But it's one of the things she gave me that I was able to give my children, was to tell me to go. She said, this is your opportunity, this is your chance. You need to go and see where it leads and what it has. You cannot stay here. This is where the opportunity is, you go. And I think it's because she regretted not having done that, because when my father was in the service, they were in California for a while. She was in San Diego and she loved it. But then when he got out after the war, they went back to Texas. And I think truly her heart, being in San Diego, that was probably the best part of her life. And then they went back to Texas, and his family was a mess. So, they always had that pressure and stuff on. And I think that's why she told me that. And very, very hard to do. My phone used to say, I love you. She and I, in fact, had to go into the bathroom and close the door to say that, you know, when I was leaving. And that always really touched me. But yeah, she and I were just in the bathroom, and she told me, you know, you need to go. You need to make this choice. You don't stay here. Because of us, you know, we'll take care of ourselves. You need to go and you need to give yourself a chance and give yourself a life. And for her to say she loved me, you know, I don't think I even knew this would be like this. But therefore, it gave me the ability to give my children wings. And I look at the people whose kids, you know, family, the parents are so involved in their lives, even people my age, and still tell them how to run their life. That's not right. You know, we have those children to raise, and then our part and our gift is to give them those wings and let them fly and trust in their abilities.
Let me ask you something here. Where you're at right now in your life, if your mom was sitting here, what would she tell you?
I haven't done that. She was so sick at the end, I miss her more now. When she first died.
Think about that time that you were just recalling when she shared that great gift with you of, you know, take this opportunity. You need
I think she would probably tell me to do what I'm doing. Work on me and do it and get on with it. And, you know, she'd be a cheerleader for me. She would be my father, you know, she'll be, it'd still be weird. But, yeah, she would encourage me.
So now that you've seen Brian work with Sydney, we're going to watch Dr. Russell Chapin work with Brian and implement the discrimination model.
Conceptualization and personalization.
Okay.
And the first one would be, again, Brian, the intention behind, and I thought this was really interesting. You had a chance during the latter part of the tape where you said to her, Sydney, you found out that her mother was a very important part of her life. And there was a point where you said to her, what would your mother think about this? What was your intention behind that?
I think at that point in time, if I remember that correctly, my intention was really to try and help her understand that her mindset, kind of how she tends to look at things, other people are going to have maybe a different way of looking at that, and really to help her get some source of strength and support that her mom would support her. That if she was going to be honest with herself and ask that question to her mom, that she'd kind of be surprised that maybe mom would tell her something, something positive, giving her some strong feedback. She'd always said that her mother was a source of strength for her, somebody that was always tended to be in her corner. And she has a lot of times that she tends to do a lot of self-doubt, not having a lot of confidence in her own abilities or skills. And so what my real goal was really trying to get her to see that that one person who was always there for you would have agreed with what your decision was, would have been there to support you in this situation too.
So to some degree, it was like giving her additional resources that she could use when she says she's confused and needs additional attention. Let's move to this personalization. This is one of my favorite parts of the tape. You were listening well, Brian, and you were thinking, I could just see the wheels turning. And every once in a while, you'd whip back in your chair and you'd put one finger on your face like this. And then there was a point towards the end of the tape where you put two fingers on the tape and you're leaning back on your chair.
Right.
What was that about? What were you doing?
Well, one of the things, and actually kind of going back to the process, one of the things as far as the examining communication is Sydney was a very verbal client. She talked quite a bit. One of the things that I think I struggled with was keeping her focused, and was part of our supervision question. And she tended to get into a lot of the stories, a lot of storytelling, trying to, I think my interpretation of that was trying to give me some background information so that I could kind of have a sense of where she was coming from. And when I would tend to lean back and do that, really what that was, and as I looked at the tape, I could really tell that was me kind of settling back and starting to listen to her story. And part of that, in all honesty, was really, you know, okay, we're getting into a story now. And in my mind, I was trying to figure out, how can I get her back to, how can I start to lead us into some process? How can I lead this back into maybe getting back more into affect, things like that? Because with those stories, she really tended to get away from the focus of either the session or maybe a particular issue that was brought up at that point in time.
I also noticed in the tape that at one point, well, several points, Sydney began to cry. And Brian, I want you to kind of think about this. You do this so well. You reflected several times, but at one point, she started to cry, and you very quickly got her out of that and asked her a question.
Okay.
What do you think might be behind that for you?
I think part of that probably would be my desire to kind of really start to maybe identify some issues. Because I know that I was frustrated at times during this session, because I saw that there was a lot of avenues that we could go down, that we could explore, that tended to, and I guess in my mind, kind of got sidetracked a little bit with some stories. So I think part of my intention behind doing that, or unconscious intention, I guess, was really to trying to get back to exploring maybe some connections between some of these past behaviors, past patterns of thinking, things like that. And so I think that was at the expense of really being able to maybe explore some of that affect.
Because I was wondering too, and it goes back to the supervisory question, if we're back, very much what we did in developmental supervision, it's asking you to be genuine. I wondered, didn't know this, but occasionally when you went like this, I knew what you were trying to do, but I wondered if the client would think, and you were so good at, honestly, Brian, listening to her, but I sensed a little bit, you said frustration, I even sensed a little bit of, this may not be right, boredom to some degree. Like, how do I get her out of this content and move her back into process and affect? And I'm wondering if it wouldn't be wise for you to maybe just share. Sydney, I'm frustrated a little bit because, you know, you are so verbal and I love hearing you talk, but every time I get you to feeling, you kind of back away. So I see a theme here as we go through these different models even, Brian. I see the theme of asking you to be as genuine with your clients as possible. Does that make any sense?
Yeah, absolutely. And after reviewing the tape, I could certainly tell that as well. That I think that it would have added a great deal to the session and really to our rapport. And like you had said earlier about the trust. But I was apprehensive about doing that for fear of what could happen if she didn't feel that I was interested in what she had to say. So I do believe there was certainly part of behind some of her storytelling was to try and help me understand. But I do agree that a lot of that was defocusing in a sense and getting away from maybe some of those painful feelings in that.
So now we're going to move on to some practical strategies that you can use within your supervisory sessions. First, kind of covering some of the basic supervision modalities. Most of us are familiar with individual supervision, where we have one supervisor and one supervisee, maybe typically 1 hour per week across a specified time frame. You may or may not be familiar with triadic supervision. And triadic supervision involves having one supervisor with two supervisees within the supervisory hour. And within this model, the supervisees are allowed more individual time. They get to staff cases. However, the vicarious learning that they experience through observing their co-supervisee experience some of the techniques or do his or her own self-exploration provides invaluable experience. In fact, it allows the supervisee time to reflect and think without having to respond. Similar to what happens in group dynamics, but it's a more interpersonal and intensive learning experience that the supervisees say is so beneficial for them. And this is actually a major model in counseling programs, especially for the first semester of practicum, where it's alternating triadic and group supervision. The last common modality is group supervision, defined as one supervisor with 3 or more supervisees. There are the same limitations that can occur with group therapy as far as the effectiveness of group. There's pros and cons. Again, the vicarious learning, the mutuality, the sharing across time and development of the group dynamics that can be therapeutic, according to Yalom's therapeutic factors. However, there are limitations in that some of the individual attention to cases is lost. However, I believe group supervision is vital if any of your supervisees are leading group. Remembering that supervision is the isomorph, and there's this parallel process. So you facilitating group supervision will also be modeling how to facilitate group, and your same roles of maybe blocking certain members, drawing out some of the silent members, is a very powerful role modeling for the group supervisees that is a great opportunity. And let's talk about some specific techniques that you can use in supervision. One of the most common and typically the most used, obviously, is supervisee self-report, where the supervisee brings in their cases, their questions. This is what's going on this week. These are our treatment goals. These are my plans for the next session. Sometimes, however, through no fault of the supervisee, he or she may omit certain details or themes. And they may not know, depending on their developmental level yet, to mention certain issues, may not pick up on certain themes, such as manipulative clients or substance-using clients. So this is why some of the following techniques, as opposed to self-report, are so important. Tape review is crucial in really being able to monitor the supervisee's skills, whether that's videotape review, audio tape review, but being able to both you yourself watch the tapes, but also have the trainee see him or herself on tape, watch what's going on, watch how they are interacting with the client. And of course, we have to be aware of HIPAA compliance and the confidentiality and security of the tapes. So typically, some sites have a requirement that the tapes do not leave the site, they do not leave the area, and this is something and to ensure that they are destroyed and deleted. And I think this can be a challenge in our digital age with iPhones and iPads and laptops being able to tape in different formats. So if you use tape review, making sure that you're monitoring and deleting tapes after they are used. Another supervision technique to consider is case note review. Case note review, I'll give you an example of in a moment, but reviewing the progress notes as that the supervisee is writing up and their documentation. Also, a technique would be to use as process notes. And a process note is going to be the supervisee's written explanation of the content of the session. In other words, it's basically like a reflection afterwards. The supervisee explains what was talked about in the session, but also the interactional processes that occurred between the therapist and the client. The therapist would also reflect on his or her feelings about the client, and also the rationale and the manner of the intervention. And I think that could be a very effective tool in having the supervisee be more intentional about the interventions and the interactions. Another technique is role play, that you and your supervisee engage in role play with certain client scenarios. This is especially effective, again, with trainees in the earlier levels of their autonomy. Role playing, some of the common fears may be my client gets angry at me, or my client refuses to talk. I can't draw them out no matter what I use. Or my client confronts me, asking me, have I ever been in recovery, or have I ever been in a domestic violence situation? And just role playing how to handle some of those difficult situations. Another technique to consider is journaling. And this may be, again, depending on your supervisory style and your level of comfort with maybe the counselor role and that personalization, but having the supervisee journal, especially across time, their experiences, their thoughts, their challenges, their strengths as they develop across time, and have that be part of a summative or end paper or project. Another technique is live supervision, and this would be very important in place of audio or videotape supervision, where you actually sit in the session with the client as they're doing their therapy. And you set parameters ahead of time. In other words, you get the permission from the client to participate, explain your role, and say that I may interrupt a couple of times through the session, or the supervisee may invite you in if there's a particular clinical issue that needs your assistance with. Another technique is BITE, which can stand for bug in the ear or bug in the eye. And this may be a luxury only in certain sites or contexts, for example, at a university center where there is a one-way mirror. But a bug in the ear is when the supervisee will be actually in session, the supervisor will be watching behind the glass of the one-way mirror, and the supervisee has a little speaker headset on where the supervisor can actually talk to the supervisee, give suggestions while the session is going on. Another version of that is bug in the eye, where it's the same setup. However, instead of a speaker in the ear, there might be a computer screen that the person can watch, and the supervisor can type comments to that. And finally, IPR, interpersonal process recall, which I'll be talking about here in a couple of moments. So to talk about the case review note example or case note review example, what I'd like to do is to pause for a couple of moments and give you a chance to read over this case note written by a supervisee. So as you read the note and you are considering then how to process this case note in your supervisory session, you may ask yourself or you may ask your supervisee some particular questions. For example, you might ask your supervisee, to what extent were your objectives for this session met? Or you might say, describe to me some relevant cultural or developmental information as it relates to this client's depression or to this client's functions within this group modality. You also might ask the supervisee or ask yourself, what is this therapist's theoretical orientation? Can I tell by reading this note what is the therapist's theoretical orientation? I might ask you to also consider what's missing from this note. And as you note what's missing, how would you word it? How would you then give that feedback to the supervisee? In other words, typically I try to start with the sandwich approach, with the positive followed by a constructive, followed by another positive. So for example, I would say here that I like the way you qualified your comments about his depression or his appearance by using the "as evidenced by." However, I note that in your assessment that you're missing the DSM diagnosis in that, and I think that that would be very helpful to include. But that also I was able to tell by the fact that you used the ABC model that you were implementing some REBT techniques with this particular client. Another comment you might make to the trainee related to this note would be how to reframe from this client looking at a deficits model to maybe more of a strengths-based model. For example, in this note, the trainee had the client rate his depression on a scale of 1 to 10, where 10 being the worst or 10 being the highest level of depression. To help aid and in the focus of conceptualization, for example, with this note, you might say, how would this scaling question look from a solution-focused model? For example, with solution-focused, the scaling is kind of flip-flopped, where 10, the highest number, is where the problem is completely gone, and 1 is the worst that it's ever been. Some other questions you might consider in supervision when reviewing a case note is asking, for example, how does this note relate to the client's treatment plan? That if say we were audited and maybe a payer or an accrediting body came in and read this note, would they see that it corroborates and coordinates with the client's treatment plan goals and objectives? Yet another question you could consider in this case note review would be asking again about what cultural factors might be playing a role in not only the client's presenting problem, but focusing on the personalization of the supervisee. What cultural factors of the supervisee might be playing a role in how the supervisee documented what he or she documented, what she noted, what treatment recommendations he or she made. So there's a lot you can do with case note review. You can really get into some rich, deep discussions about some of these. Again, the goal to bring more intentionality and self-awareness on the supervisee's part. I mentioned this a couple of slides ago that I was going to talk a little bit about IPR, or interpersonal process recall, developed by Norman Kagan. And IPR is a technique used during either role play or video or audio tape review. And with IPR, the goal is to use different leads to open up psychological barriers, to open honest communication, and also maybe open honest self-exploration. So some of the IPR leads, again from Kagan, include affective exploration, asking questions like, how did that make you feel? Or what do those feelings mean to you? What did you do or decide to do about the feeling you had in that moment? And again, these would be leads where you could stop the tape, you could stop the role play, and have that supervisee think about their process and think about their feelings. You might also use leads to check out unstated agendas. For example, what would you have liked to have said to him or her at this point? Or if you had had more time, where would you have liked to have gone? There are other leads in the IPR model that encourage cognitive examination. For example, what were you thinking at that time? Again, not asked in the sarcastic way, like, what were you thinking? Were you able to say it in the way you wanted to? Did you have any plan for where you wanted the session to go next? You might also consider some leads that get at images. For example, were you having any fantasies at that moment? This can be kind of getting into sometimes when the clinician's mind wanders. Were there any pictures, images, or memories flashing through your mind then? Where had that put you in the past when you went off and thought about those images? There's also leads that can explore mutual perceptions between the client and the clinician. For example, what did you think that she or he was feeling about you in that moment? Or how do you think that she or he was seeing you at that point? Was she giving you any clues as to how she was feeling? And there may also be leads that search out expectations. And this relates a little bit to hidden agendas, but what did you want him or her to tell you? What did you want to hear? Or what did you really want to tell him in the moment? And what prevented you from doing so? Again, this is the interpersonal exploration and intrapersonal exploration that I'm sure you can see how these leads and these types of questions can assist to break down the psychological barriers and open up that rich, deep communication in the supervision session to help facilitate that growth. I want to give an example of IPR, or interpersonal process recall, and we're going to watch a clip here in a moment of Max. And Max is seeking counseling with his therapist, Julia, regarding some marital difficulties. And this is their first session. So take a few minutes here and watch the clip of Max.
Okay, Max, I understand that you have some concerns that you'd like to discuss today. So whenever you're ready, I'm happy for you to voice whatever it is that you'd like to talk about.
Yeah, well, I suppose the bottom line is I'm having some difficulties in my relationship with my wife. And I'm very uncertain about actually being here, and it's a bit embarrassing talking about these things with a stranger.
Yeah, so you're feeling a little bit uncomfortable discussing such personal information with an outsider?
Yes, it is. I'm a bit awkward. I was brought up to solve your problems yourself.
Yeah,
And you don't go outside the family, you don't take your problems to strangers. And I would normally do, but also I realise now that given the depth of the problem, that I also need to get another perspective on things.
Okay, all right. I guess what I generally say to people when they first come along is that it's not uncommon to feel quite uncomfortable talking to an outsider about such personal information, and even though I can't predict exactly how you're going to feel and how things will go for you today, I do know that in the past a lot of other people have actually felt quite uncomfortable to begin with, but as they've been able to talk and get things off their chest, they actually feel quite relieved. So you might find that as we spend more time together, that you're more comfortable in this environment too.
Well, I hope it works out that way.
Yeah, we'll see how we go.
Well, it was a friend of mine who'd been involved in counselling previously who suggested that this is what I should attempt to do anyway. See where we go.
Okay. And you were saying before as well that that normally you like to solve things yourself and work things out yourself, and I think it's quite a balanced perspective to be looking at how you're going to resolve things yourself, and also to get an outside perspective as well. So I can see lots of benefit that can come from that dual approach.
Well, I haven't succeeded in doing it by myself, so
yeah,
it's worth a go.
Yeah, so perhaps we can shed some light on some helpful approaches for you. Yeah. Okay. I guess to help me understand your situation, it'd be helpful if you could talk a little bit about what's been going on for you and what's brought you along.
Well, I suppose things have just deteriorated in my relationship with my wife, Angelina. We've been married 11 years now, and we've got 2 kiddies, John who's 9 and Jackie who's 7.
Right.
And she's very busy in her job, and she's always been I suppose a bit of a control freak.
Right.
She likes things to be just so. And occasionally she would, what I would call it, lose the plot, and she'd yell at me and abuse me. But in the past that was never a problem, because we could sit down and talk about it, and she'd recognise that she'd probably gone over the top and whatever. But lately it's really just gotten out of hand, and she's not controlling her anger or temper, and it really concerns me now, because I think it's starting to affect the kids.
Right, okay. So it sounds like, to begin with, she might often become quite angry, but she would settle down and you could resolve things, but of late it's become a lot more volatile, and she's become more explosive, and you're really concerned about the impact on yourself and the children.
Yeah, I mean, the kids are young, and I mean, John, he's a boy and he seems to be handling things okay. But you're always uncertain as to really how things are affecting him. Jackie's only 7, as I said, and she's a lot more sensitive, and she's not really handling things too well at all. Yeah. And that's really starting to put a lot of extra concern to me.
Yeah, okay. So it sounds like you've got a lot of concerns about both the kids, and John's probably handling it okay outwardly, even though obviously he's feeling it. But Jackie, you're particularly concerned about, because she's quite delicate, and you're worried about that impact.
Yeah.
And all of you are walking around on eggshells at the moment, just waiting for some kind of explosion to happen. Does that sound right?
Well, I'm concerned about the kids, but I'm concerned about the marriage. It's important to me to do what you can to keep things together, because that's better for the kids.
Yeah.
But if I had to single out one major concern, it would be probably for Jackie.
Okay.
Because there's been a few incidents lately where the kids have been exposed in...
So I'd like to ask, what are some IPR leads that you might consider if you were supervising Julia and had watched the tape of this session? Some possible examples based on this clip. How did it make you feel when Max said that it was embarrassing to be talking about marital issues with a stranger? Or was Max giving you any clues as to how he was feeling about his wife? And I think you could go deeper here than just Max's body language, although depending on her level of autonomy, her level of cognitive complexity, she may pick up on his nonverbals, or she may pick up more on the content of his discussion about his wife and his story. You might also ask, well, what did you want to tell Max when he shared that he was brought up to solve his own problems? And kind of get into that. How did that feel for you, given that this was your chosen profession? So you can have, again, some very rich discussions about these different topics, and using these leads in a practical way to help your supervisee with his or her development. A few more supervision activities that you might consider. I mentioned this before, but to tape or transcribe a session. This is one of the activities that usually results in a lot of grumbles, especially because it's a very time-consuming process to sit in front of the computer, have the supervisee listen to the tape over and over and over again and type word for word what the client said, what the counselor said, what the client said, what the counselor said. However, it is actually one of the most effective tools. And also with that transcription, you could look at adherence to theoretical perspective. Again, we're applying theory using these evidence-based techniques. Some supervisees decide to invest in some of the software that will go ahead and transcribe it, and then they go and supplement and check it. So it depends on their level of commitment, I suppose. Another activity might be to write a weekly reaction paper to their session, their work, to track their progress towards their supervision goals. And then a summative paper at the end, describing, maybe taking all the different components of training, the clinical interventions, the personal explorations, the consultation, the implementation of ethics, the adherence to cultural diversity, and synthesizing those into a final summative paper. And one final activity that I would recommend, and I think this goes along with my mantra of working smarter instead of necessarily harder, and that is to have the supervisee write their own reference letter at the end of the experience. Because you can pretty much guarantee that they are going to request a letter for future employment purposes. And having them write their own letter and having them detail what were their work behaviors, what did they do in this clinical experience, what are their strengths, what are their areas for improvement. It has them self-assess so that they can look at themselves through someone else's eyes. And of course, they send you the letter, and of course you read it, amend it, add to it. However, it does help you reflect and helps the supervisee reflect on the experience and what their goals and that they met and what future goals they may have. So kind of a little trick of the trade at the end of that experience. So I want to talk also at this point about some of the supervision basics. And in this section, I'm going to talk about first the idea of becoming a supervisor. Some of you may have already been doing supervision. Some of you may be considering, do I want to add this to my professional repertoire? So some of the benefits of becoming a supervisor, and some of these are related to taking on an intern, but maybe to have an extra set of hands to do some of the work. It provides you job variety, whether you're doing clinical work or administrative work. Providing clinical supervision adds to your own variety. It keeps you up to date because you do, when you have an intern or a supervisee coming to you for information, it keeps you up to date on what are questions going on, what are the current techniques being used, what does the research say about how to address this clinical issue. With interns, it's a possibility for screening for future hires, this is a way to basically have an extended interview of someone's work behaviors. Some see it as a way to give back to the profession, a way of paying it back, since we've all, at some point to get to where we are today, have had clinical supervision. And it is definitely a method of personal and professional growth. It is such a way to expand your wisdom and your knowledge and kind of support what you know and how you do it. There are some limitations in that it is time consuming. At times. You are going to be basically taking on the training and monitoring of another person. There is the liability that comes with your legal and ethical responsibilities to monitor the supervisee. Of course, more responsibilities with regards to documentation and paperwork. Again, documentation of your own supervision sessions. There is the cost of liability insurance, which I'll talk about here in a few moments. And it can be challenging, which is usually a good thing for us. But just remembering that it is a way to pass on your professional wisdom and experience, which is really invaluable as we train a new generation of clinicians. So some of the basics, and we're going to go over each of these one by one. We're going to talk about expectations in supervision, the supervision contract, documentation requirement, accordance with ethical and legal bodies, attendance to culture and diversity, and at the end, evaluation and gatekeeping. So as we talk about expectations, we need to review at the onset of supervision both your own expectations about supervision and your supervisee's expectations. Again, the supervisee comes to supervision from possibly no experience whatsoever, not knowing what to expect from the supervisory process. And they move from low autonomy and high anxiety to higher levels of independence and skill. And so you are going to provide an orientation to supervision to the supervisees that are in this lower phase, the novice phase, that may not have that experience, but realizing that they're going to change as they gain experience. So we're going to talk about Stoltenberg's IDM, or the Integrated Development Model. And what this model says, this is from Cal Stoltenberg, is that the supervisee is going from this novice professional through the experienced professional phase and then ultimately to the senior professional phase. In fact, when we talk about becoming a supervisor, typically it is the clinicians in the senior professional phase that feel more competent to provide clinical supervision. So I want you to consider where the supervisee is at as you're providing the supervision, and asking yourself, how will you conduct supervision with a novice versus a senior professional, because those are going to look different. And to remember that not only of meeting the supervisee where he or she is at, but also allow chances for the supervisee to tolerate ambiguity in order to grow. For example, when a supervisee is coming to supervision and they're very frustrated that they have a completely nonverbal client that refuses to talk, rather than just giving her a list of suggestions and just saying, try this, do this, do this, try to engage her in the process. Help her figure out how to figure it out herself. In other words, where can you go to explore this? Where can you go to find information about nonverbal clients or reluctant or resistant clients? And even focusing on the personalization. What would be the worst thing that could happen if the client continues to refuse to talk? And get her to think through that process and that conceptualization. And remember, this is not a lockstep approach. That's a very predictable progression from novice to senior professional. It's going to differ from supervisee to supervisee based on their exposure to the clinical issues, based on their life experience, based on their work experience. I want to talk a little bit about the supervision contract. And supervision contracts are in some ways similar to informed consents that clients sign when they begin treatment. But a supervision contract is going to outline the frequency, duration, and time of when your supervisory sessions are. And I think this is important because it's very easy with the very hectic clinical responsibilities and agency responsibilities that you can't have a set time. But I think if you treat it as if it were a client appointment and you honor that time and you block it off and make it a priority, I think that really, first off, it would support the contract that you're devising, but also remind both you and the supervisee of the importance of it. You set the location. And if there were any fees, this wouldn't apply to any interns or practicum students, but for example, some supervisors do charge for supervision, for the pre-licensure supervision in varying ways. Your supervision contract does outline the purpose, the goals, and objectives of supervision. It outlines the methods and modalities used. And this would include, for example, your theory of supervision and whether or not you're going to use tape review or note review or interpersonal process recall. This would all go into the supervision contract. It's going to outline the responsibilities of the supervisee. And I talked about those earlier in the presentation, and so those would be in your contract. But I also want to add here about crisis notification. And this can come up as a liability issue as well. But I think it's really important that your supervisee understand when to call or come get you as the supervisor if there's a crisis. and what can wait till the next business day. For example, if let's say the client at 6 p.m. and the client that the supervisee has is suicidal, that's something that you would talk about with your supervisee, that I want to be called on my cell phone, even if it is after hours, when you have a clinical emergency like that, or I want you to call the clinician on call, but kind of outlining that. And also the means of contacting the supervisor, whether that's via cell phone or email or office, but especially with crisis situations of when and how to notify. In the supervision contract, you're going to talk about the method of evaluation. How is the person going to be evaluated? What aspects? Is it related to reliability with regards to being on time and keeping appointments on time? Is it related to initiative? Is it related to, are they going to be evaluated on how well they implemented CBT techniques over the course of supervision? I think you also need to discuss the limits of confidentiality within supervision. With confidentiality, because you are in a gatekeeping or an evaluative role, it is somewhat limited, much like if a client is a danger to himself or others, and you have to break that confidentiality. If your supervisee is a danger to clients or having some sort of an adverse effect, you cannot necessarily guarantee that what is discussed in supervision will stay there as long as you are complying with the due process requirements that you outline in your contract. Another piece of the contract would include your credentials and disclosure statement, including your experience and training in clinical supervision. And I also add a piece in the contract that the supervisee, and of course myself as well, will adhere to the corresponding codes of ethics, whether that's APA, ACA, etc. It is very important, just as with clinical notes, to document the supervision session. So I encourage supervisors to keep a supervision note that will detail some of the, not only the topics being discussed, but also some of the structural monitoring. For example, we'll talk later about 100 hours of supervision being required in no less than 50 weeks, and how that will look for the board when you have to count and keep track of and document the hours. But this is one example of a supervision note that would include the report of supervision, the date, the time, where it was located, the names of the persons present, if this was, for example, triadic or group supervision, and the summary of the content of what was discussed, any assessment or evaluation of the supervisee. This note can kind of prompt you to remember to evaluate and provide feedback about that, and plan for the next session, and possibly any comments that occur with that. So I think this is one way to keep track of it. Another trick of the trade I do, and I kind of model this for my supervisees, is we do the note together at the end of the supervisory hour. So when there's about 5 to 10 minutes left, I give a prompt and we write together, okay, what stands out to you about what we talked about today? And I have the supervisee tell me what they remember. And then I also process out loud what stood out to me and what I remember, so that the supervisee can hear me and hear my thoughts and my conceptualization. And because eventually the goal is you want to get them to start thinking like a supervisor. And this helps kind of get this in their head. And so you document together. And then that way it's more structured, where you can talk about, well, this is my assessment and evaluation of your cases or your skills for this week. And so making that a more structured process. It also saves you time that you're not having to then kind of multitask and continue to document after the supervisory hour. Another one of the practicalities of supervision is knowing that, of course, we have to ensure accordance with ethical and legal fulfillments for our supervisees. So especially when you are orienting your supervisee to the process, when you are talking about adherence with ethical codes, ensure that your supervisee knows the limits to confidentiality and knows the reporting laws. For example, if their client discloses abuse or neglect of a minor or incapacitated adult, knowing that, first off, that the supervisee has verbally informed the client of the informed consent and their limits to confidentiality, but also letting them know that, for example, that they're in supervision, because that is another limit to confidentiality, where the supervisee needs to say that, you know, I am in supervision and I will be discussing our cases with my supervisor, but then it's about my training and learning in the process. You also are responsible to ensure that supervisees are implementing evidence-based practices, that they are not kind of going off and doing some techniques and things that are not necessarily conducive to positive therapeutic outcomes. You also may consider a liability insurance rider if you have liability insurance. For example, there's one that's a consultation rider that kind of covers some of the liability as you're monitoring someone else's clinical work. This, you know, varies. I'm sure it varies based on your insurance policy. Usually it's about $25 a year. Because there is, of course, a vicarious liability that you have as a supervisor, the legal term being respondeat superior, which means let the master answer. And hopefully this doesn't come up too often. One case I'm aware of was where a clinician, a postgraduate clinician, was doing in-home therapy, and it was the therapist ended up entering into a sexual relationship with a minor female during the course of the in-home therapy. And there was a successful case where the supervisor was sued and the agency was sued for failure to monitor, that there should have been, that they should have known that this was a possibility and should have monitored and intervened. So again, hopefully that's a very rare occasion, but if it were to occur, definitely you have that vicarious liability to consider. Also, some of the supervision basics is to ensure attendance to culture and diversity. For example, I know in the counseling program, in our model, we are trying to place interns in sites where they have access to clients representing ethnic and demographic diversity. And so this would be an example of making sure that the supervisees are getting access to a variety of clients when possible, whether that's clinically or culturally. And considering some of the cross-cultural variables in your supervision, race, ethnicity, gender, sexual orientation, religion, class, socioeconomic status, etc. Because it's not just between your supervisee and their client, even though that does need to be addressed. It can also be between you and the supervisee. Sometimes there are cultural differences in conceptualization, sometimes there's training differences, but not forgetting there may be some cultural aspects going on within your dynamics. And Darcy Granello has a model where she uses Bloom's taxonomy and applies it to cultural issues and cultural competence. So, of course, Bloom's goes from knowledge, comprehension, application, analysis, synthesis, and eventually to evaluation. But realizing that sometimes, especially with the lower autonomy supervisees, that you're focusing more on knowledge and comprehension. However, once the supervisees get into the analysis and upward stages, they should be expected to integrate more of the cultural components and be able to process this as it applies to themselves, their clients, and the supervision. And finally in this section, we have evaluation and gatekeeping. because this is a reality of supervision, whether we're talking about in the pre-graduation realms or even post-graduation, pre-licensure, or even post-licensure. But if there is some sort of an assessment used, for example, a university form or instrument, I always attach that to my supervision contract so that the supervisee is aware of it and knows what they're going to be evaluated on. I think it's also important to obtain multiple data points, not only to make sure you're seeing all the supervisee's strengths and things that they're doing well that you may not notice or you may not see in your context, but also if there are any concerns. Kind of ask yourself, okay, is it just in supervision? Is it just within our dynamics? Or is it happening with other colleagues at the agency or at the site? And then most importantly, asking, is there a parallel with the client? Are the concerns I'm having or I'm seeing or I'm experiencing, is the client experiencing them as well? And this is where it's so important of your documentation you've had of your supervision sessions, your watching the videotapes and reviewing those tapes to ensure that any adverse effects are being monitored and handled. Because I think it's really important that we communicate, and so I have communicate. If they don't know, then they can't change. And so we can have our concerns, and it is our responsibility to communicate so that they have the opportunity to remediate. Hopefully most of us or hopefully none of us are in the practice of kind of unfairly trying to drop a bomb and on a supervisee and kind of get them kicked out or anything like that. Hopefully that's not any of our style. But we do have to give them the opportunity to remediate if it is an appropriate deficit or skill to remediate. And if they cannot, and if they either cannot or do not remediate any of the deficits, then it is appropriate to proceed with a more formal process of removing the trainee from the client contact. Again, following due process. I would also recommend too, if you have any concerns, especially towards the more serious end, that you consider a second opinion from a peer. You send that, whether that's somebody else to begin supervision with the supervisee to confer with or to confirm some of the suspicions, and again, document any consultations. In our last section today, we're going to talk about the credentialing of supervisors. So I want to talk a little bit about the state of Florida and its requirements for becoming what's called a qualified supervisor. For Florida Board 491, this board, of course, covers the professions of mental health counseling, clinical social work, and marriage and family therapy. And there are different requirements in order to be a qualified supervisor of these different professions. And remembering that with Florida Board 491, there's typically 2 years of postmaster's requirements of clinical work. And this is where the 2 years that is the supervisee or the registered intern is working has to be done under the supervision of a Florida qualified supervisor. In general, for all three of the professions here, a qualified supervisor must hold an active Florida license and typically has to have a 16-hour supervision class or a 3-hour graduate level supervision course. There may be profession-specific coursework required, and also clinical experience of your own as a clinical supervisor. So I'm going to talk a little bit about these three professions, and this Board 491 requirement went into effect in February of 2000. So the link here is on the slide for you if you would like to read these specifically. However, the requirement for a qualified supervisor is that effective in 2000, any individual serving in the capacity of a qualified supervisor for registered interns in Florida must have completed training and supervision defined by the rule and chapter of the Florida Administrative Code. Determine if you qualify to provide supervision. And what's important is that the training that you get, it has to be subsequent to licensure. So, for example, if you took a graduate level supervision class, but you weren't yet licensed, then that would not count. You would, after licensure, have to take either the 16-hour, the 2-day workshop on supervision, or take a regular 3-hour graduate level class. For the Board 491, for supervision of clinical social work and marriage and family therapy or mental health counseling, the following, two of the following 3 steps have to be completed. Again, completing a supervisor affirmation statement, which is part of the application, and complete the education verification. And this is where it can get somewhat complicated, because if you are wanting to supervise across professions. For example, if I as a mental health counselor want to supervise clinical social work registered interns, or if I want to supervise marriage and family therapy registered interns, I have to provide certain documentation that I have had coursework in those programs. So again, you send your application and the supporting transcripts and documents to the board, and once you are approved, it will be basically an addition to your license. You'll get that qualified supervisor designation, in which anyone can look you up to see if you would be able to supervise for that postgraduate pre-licensed hours. So just briefly, if you are interested in supervising clinical social work interns, again, the same educational requirements that you have to have had training and supervision. You can be what's called an AAMFT approved supervisor, it's the Association of Marriage and Family Therapy, or you can have a postgraduate training course for field instructors specific to clinical social work. In here, with the social work, you have to have had 4 years of clinical social work experience, 2 of which could be earned during your postmaster's clinical internship or your registered internship. So if you are not an LCSW, if you're not the licensed clinical social worker, in order to supervise registered clinical social work interns, you will also need to provide documentation that you've had a minimum of 9 semester hours, so 3 classes in a graduate program of social work. And then it lists the possible classes that would count towards that. So many of us, for example, my degrees are in counseling. They weren't within the School of Social Work. I would have to go and take 3 additional graduate level classes in the field of social work in order to be a qualified supervisor for clinical social workers. And these are the requirements for supervising marriage and family interns. Again, similar with the educational requirements of having a graduate level course or training. You can be an AAMFT approved supervisor. For marriage and family, you need 5 years of clinical experience in marriage and family therapy. Again, 2 of which can be during your registered internship. So this would mean 3 years post-licensed with the experience requirement. But if you're not an LMFT and would like to supervise LMFT registered interns, you would have to document that you've had a minimum of 6 semester hours of graduate coursework in marriage and family therapy. And of course, you'd have to provide transcripts to support that you've had those courses. So the next slide here talks about the Board 491 requirements for mental health counseling supervision. And I realize the writing on this slide is kind of small, but you can actually go to the website a couple of slides back, and it will give you all this information. But in order to supervise A registered mental health counseling intern, again, you can have the educational requirements of coursework or workshop, or you can be what's called an ACS, or an approved clinical supervisor, which is designated by the Center for Credentialing Education. It's a part of NBCC, or the National Board for Certified Counselors. You can also be an AAMFT approved supervisor, or a postgraduate training course for field instructors in clinical social work would also satisfy that supervision requirement. For mental health counseling, you must have 5 years of clinical experience in mental health counseling, 2 of which could be earned during your postmaster's registered internship. So again, the same with marriage and family therapy supervision, 3 years post-licensure work. If you're not an LMHC, in order to supervise the registered mental health counseling interns, you would also need to provide documentation that you've had a 3-semester graduate level coursework in some of the following areas that are specific to counseling. Also note that if you are licensed as a psychologist in Florida, you can complete a minimum of 3 years of experience providing psychotherapy, consisting of a minimum of 750 hours of direct client contact per year to qualify as a supervisor for Board 491. So because there is this cross-pollination, so to speak, of the different professions, and this kind of gets into an area of hopefully not contributing to the silo effect between the professions. But I think it's important that if you're going to be cross-supervising, that you know a little bit about the professional orientations and some of the subtle differences in the mental health helping professions. So sometimes I review this slide with supervisees, and we talk about maybe some of the differences in training models, and I'll briefly review this. And I definitely compare it also to some of the other helping professions that we work with in the different sites and agencies. So for example, psychiatry, the terminal degree for independent practice is an MD or a medical doctor. The educational background and training is in medicine. And the philosophical basis is going to be in the medical or the disease model, where there is this a disease that is to be treated. The professional association is the APA, or the American Psychiatric Association, not to be confused with what we're about to cover, APA, the American Psychological Association. And I point out to supervisees that this is the APA that, of course, produces the DSM. Of course, psychiatrists are part of the American Psychiatric Association and also AMA, and they are licensed as medical doctors, and they also can get board certified in psychiatry. Next is psychology. The terminal degree for psychology would be either a PhD or a PsyD, the Doctor of Psychology. The educational background has been traditionally in the Boulder and Vail models, whether it's a scientist practitioner or science-informed practitioner. The philosophical basis traditionally has been in the medical and disease model, again, where there is a diagnosis or a symptom to treat, although more recent models do get into aspects of positive psychology and strength-based approaches. The professional association is APA, or the American Psychological Association. And again, APA Code of Ethics. I like to point out to some supervisees that this is the APA that does the publication manual for, of course, APA style. And psychologists become licensed as psychologists. Next is social work. And social work, the terminal degree is going to be a Master's of Social Work, although some programs have an MA, a Master of Arts or Master of Science. The educational background is in social welfare and advocacy. And the philosophical basis for social work is in negotiating social systems. The professional association is the NASW, the National Association for Social Work, and the codes of ethics include the NASW or the CSWE. And the license for social workers is going to be the LCSW, the Licensed Clinical Social Worker. Next, we have marriage and family therapy, where the terminal degree will be a Master's of Family Therapy or a Master's of Marriage and Family Therapy. There will be a Master of Arts or a Master of Science, possibly, depending on the program. The educational background is systems theory, And the philosophical basis is looking at the individual in the context of their lives, in the context of other relationships, not looking at a person as completely separate from their other systems. The professional association is the AAMFT, and the codes of ethics include AAMFT or COAMFTE, and the license is the LMFT, the Licensed Marriage and Family Therapist. And last on this slide is counseling. Counseling, the terminal degree, will be a master's degree as well. It may be a Master of Arts, Master of Science, or Master of Education, depending on where the program is housed. The educational background comes from a developmental model, for example, where it's believing that people do the best they can with what they have, and also meeting people developmentally where they're supposed to be at. The philosophical basis comes in the form of wellness focus, strength-based focus, and prevention. Our professional association is the ACA, or the American Counseling Association, although school counselors typically belong to ASCA, or the American School Counseling Association. In our codes of ethics is ACA, which is the American Counseling Association, and our accreditation is through CACREP, the Council for Accreditation of Counseling and Related Educational Programs. The license here in Florida is an LMHC, which is a licensed mental health counselor, although the majority of states in the country refer to it as the LPC, which is the licensed professional counselor. And again, school counselors don't get licensed in Florida, they get certification. So I go over this in case you are cross-supervising across some of the different professions, for example, with Board 491. And that way you have a little bit of insight into some of maybe the different conceptualization models with which a supervisee might present in the supervision session. So I think it's also important too that you are aware of the specific requirements among the different professions in order to get licensure if you're providing that pre-licensed supervision. So for example, with Board 491, with mental health counseling, you have to provide 100 hours of face-to-face supervision for every 1,500 client contact hours in no less than 100 weeks. And so this will hopefully help keep you on track as far as scheduling and when to meet to provide that supervision. You must have individual supervision at least every other week, so it can't be just group supervision the whole 2 years. And if it's group supervision, there can be no more than 6 in a group. So at the end of the 100 weeks, or the 2 years, the supervisor must create and send a signed letter to Board 491, actually stating that the supervision has occurred and completed. There's actually a form. Before the supervision can occur, the supervisor must create and send a signed letter to Board 491 with their intent to supervise. And again, with the supervision, the supervisor must be in the same room. There's no cyber supervision. Another national credential you might consider is the ACS, or the Approved Clinical Supervisor. This is a credential that attests to the educational background, knowledge, skills, and competencies of an approved clinical supervisor. And I have the link here on the slide if you're interested in learning more about that. Typically, the requirement would be a master's degree or higher in a mental health field, and you would be licensed as a mental health provider or certified as an NCC. And you would have a graduate clinical course in supervision, and a total of 30 clock hours of workshop training in clinical supervision. Also, you must have endorsement from a qualified supervisor attesting to your supervision experience. I want to end by revisiting the perspective that we used at the beginning of this webinar, and that is revisiting your recollections and your own experiences with supervision when you were a supervisee. And because clinical training is so important, several researchers have looked at aspects of effective supervision. However, these researchers asked the supervisees themselves what accounted for both good and bad supervision. And the following list integrates the list of features to remember to avoid being what's called a lousy supervisor. So for example, don't reveal any of your own shortcomings to your supervisee. Don't provide a sense of safety so that your supervisee can reveal his or her doubts and fears about competency. Place the importance of service delivery above your supervisee's educational needs. Don't support your supervisee's strengths, only point out weaknesses. Involve your supervisee in the conflicted dynamics among professional staff in your setting. Also, continuing the list of how to be a lousy supervisor. Allow yourself to feel threatened by your supervisee's competencies. Insist that your supervisee work from the same theoretical orientation as you do. If you sense the presence of conflict in the relationship, don't bring it up. Treat your supervisee as a confidant. Use him or her as a counselor. And finally, be sexist, ageist, multiculturally incompetent, and the like. I'd like to thank you for your attention during today's webinar. I hope you found this information beneficial for your professional development. The following slides contain references for your convenience. Thank you.